The history of treating gonorrhea is a story of lost weapons. Each new antibiotic once promised hope, only to be outmaneuvered by a remarkably adaptable foe. Penicillin once cured it with a single dose, until resistance emerged. What was hailed as a miracle quickly became a cautionary tale. The bacterium developed enzymes to destroy penicillin, forcing doctors to switch drugs. Each adaptation was a warning that the battle was far from over. Tetracyclines and spectinomycin worked for a while, but resistance soon followed. The bacteria's ability to evolve outpaced our medical advances. Gonorrhea altered its targets and built pumps to eject these drugs. It was as if the microbe was learning, adapting with every new threat we threw at it. By the 1980s and 90s, these treatments were unreliable. Doctors watched as their trusted medicines failed, and patients faced growing uncertainty. Fluoroquinolones like ciprofloxacin became the next hope, but resistance spread rapidly. The optimism was short-lived, as the bacteria adapted yet again. Within a decade, these drugs were nearly useless in many regions. The world watched as the list of effective treatments shrank alarmingly fast. Today, dual therapy, ceftriaxone and azithromycin, is our last reliable option. These drugs are now the final line of defense, used together in hopes of outsmarting resistance. But cracks are showing. Resistance to both drugs is rising. The warning signs are everywhere, and the medical community is on high alert. We're running out of effective treatments. The options are dwindling and the consequences could be catastrophic. The pattern is clear. Every time we find a new weapon, gonorrhea finds a way around it. The cycle of innovation and resistance continues, relentless and unforgiving. The threat of untreatable infection is no longer theoretical. It's a looming reality, casting a shadow over modern medicine. We're closer than ever to the edge of an era without cures. The clock is ticking, and the world must act before time runs out. For healthcare workers, treating gonorrhea is now a high-stakes challenge. The once simple cure is no longer guaranteed. Doctors must consider resistant strains with every patient. Failed treatments mean ongoing infection and further spread. Patients suffer longer, and complications like infertility become more likely. Follow-up testing is now essential, adding strain to healthcare systems. In many places, returning for care is difficult, letting resistance spread undetected. Clinicians face a dilemma: treat now and risk resistance, or wait and risk harm. Dual therapy is a stopgap, not a solution. The arsenal is shrinking, and anxiety is growing. What happens when the last tools fail?